muting themselves. Take it away, Rebecca.
Hello, good morning. Thanks for inviting me. I have to say, when Suraj asked me to speak, I kind of thought I'm not really sure what a group of retrieval doctors and paramedics would like to know about community care. We're really at the other end of the spectrum as far as acuity. But Suraj and Dr. Richmond, who I really dumped me in this, assured me that you would be very interested. So I thought I'd just try and give you a rundown of what we've set up for COVID community care and what we've done over the last 3 months. It's on a basis of a system that was set up to manage the hotel quarantine health hotels. So for the last 18 months, RPA Virtual has been providing the medical and a lot of nursing and allied health support to patients who are in one of 3 health hotels. So there were 24 police hotels and 3 health hotels coming in from overseas, and anyone who was COVID positive came through those health hotels. We concurrently run a community COVID program, which until July was very low volume, and then it ramped up considerably. Need to work out how to actually change. So I think we've sort of been saving lives from a computer. That's the way I like to think about it. So the goal of our COVID protocols was to stop people dying in the community and to get them to hospital before they were in extremis, before they needed a resuscitation team to meet them there, and hopefully to avoid sort of urgent intubation scenarios in ED for people who are acutely deteriorating. Picking which of those patients in the community sort of fit that model, getting them in early but not too early, not sending in too many people who didn't need to go, was pretty challenging, and we've done a number of revisions of our model to try and get that balance right. We've managed patients in 2 settings. So there's the SHAR, which is a special health accommodation. We've managed about half our patients through that system. There's 3 hotels. We went up to 4 briefly and then back down to 3. There's about 900 beds in those 3 hotels, and at any given time we've been looking after about 700 COVID patients within those 3 facilities. Generally, they're higher complexity than what's in the community. We've had, especially in the last month, a lot of people with concurrent mental health and drug health problems, but also a lot of people coming out of hospital who are frail, elderly, mildly unwell, probably don't need hospital admission, but we're a bit worried about them, and a lot of people who are vulnerable from a social perspective. Then we've concurrently managed anyone with COVID in the community in the Sydney local area health district. So we looked after over 12,000 COVID positive patients since March last year, but 9.5 of those have been since July this year in this current Delta outbreak. That's less than Western Sydney and less than Southwest Sydney, but still a reasonable number. At our peak, we had 3,000 patients who had active COVID infection on the books. That was a pretty tough couple of weeks. And so just having a look at some of our data over the last few days, we've just sort of had a little bit of breathing space now to try and start reviewing the data and really know what we've done and who we've looked after and what the impact's been. So we had 8,500 patients registered from the 1st of August to the 12th of December, so yesterday. We had about 1,500, or a bit over 1,000 from the 15th of June to the end of July. I haven't included them in this data set because we changed the system that we were using, so I just couldn't measure it last night. Since the 1st of August, we've done over 5,000 medical reviews, about half of patients in SHAR and half of patients in the community, and we've moved about 1,000 patients to ED over that 2-month period, bit over 2.5 months. So I just thought I might go through how we end up with patients sort of on our books and what happens in virtual care. So this is the positive pathway. So if a patient gets a swab, and it really depends on how many days they've been sick for before they get a swab, which can really impact on how unwell they are when we see them. But they get a positive swab. It goes onto a database called NSIMS, which is a public health database. Public health used to refer them to us following that. In the last month, there's been a change to a patient flow portal, and then they get directly allocated to us based on that, and that's a ministry managed portal, and then we register them off that. Once they've been registered, we take them through a risk stratification process, and then we do an initial assessment, and their model of care is based on their risk. So for the first 3 months of this, we've only had medium, high and very high risk. We didn't think we could identify a low risk group when we first assessed our first sort of 500 and then 1,000 patients. Low risk being a group that didn't need an oximeter that could self-escalate, and medium risk being a group that needs an oximeter, can self-escalate, probably don't need a lot of supervision, but need more than than your standard sort of respiratory illness. If they get sick, so they're reviewed daily if they're high risk by nursing staff, and if they get sick or they meet any red flags, then they get escalated for a medical review. Then at the end of their 14 to 20 days, depending on which category they fit into, they get de-isolated and discharged, and that's involved a clinical review, which has actually been a massive amount of work and has really impacted on all of the services' ability to maintain acute review systems, because we've had to put a lot of workforce into both the initial assessments and the de-isolation around the model of care and looking after people in the middle. So this is the risk stratification that we used for the first few months, and we've just changed this to add on a low risk group. So basically if you were vaccinated, that made you less risky. We went with the age group of 50, which is less conservative than Canada and more conservative than the UK. So Canada's high risk group is above 40 and the UK was 65, and relevant medical history and very high risk medical history. So based on age and comorbidities, and it was a lot of the standard stuff. So if you've got ischemic heart disease or previous lung disease, cirrhosis, a significant disability, etc., then you're automatically high risk. If you're medium risk, we had drivers delivering oximeters to the community, and in the SHAR you'd get vital signs done twice a day. High risk got oximetry and then 1 or 2 nursing calls a day, and very high risk got oximetry, a medical review on admission, and 2 to 3 nursing reviews a day. And the very high risk group were people who almost always ended up in hospital. It was just a matter of which day they went. We've now identified a low risk group, which is fully vaxxed under 65 with no significant medical or social risk factors, and they will, moving forward, be moved to primary care for general practice to look after. I'm not going to spend too much time on this, but this is our protocols and our risk stratification. It's pretty similar to what we're seeing internationally. Medical escalation. So we looked at our first 1,000 patients in July and sort of tried to pick out some themes, and then did a significant data review of what the flags were for deterioration later, and found that if you had really high volume GI symptoms, vomiting, a lot of diarrhoea, terrible abdominal pain, etc., you're much more likely to become hypoxic later. A lot of people had chest pain, syncope, and significant postural symptoms also indicated more severe illness later on. So they all became red flags, along with just using your between the flags chart. Children, did reviews mainly for children for persistent fevers, poor oral intake and parental concern. I think we sent 1 child to hospital in the last 3 months for respiratory illness, and that was I think a 4-month-old baby with what sounded like bronch, with very mild hypoxia, and every other child we sent to hospital with illness, it was for gastro and poor intake things, or something that wasn't COVID. We sent a lot of children to Westmead to do the home in the hospital who are unaccompanied minors, and I'll talk a little bit more about that shortly. So the way we managed our escalations, if the nurses identified that somebody had a red zone vital sign, so SATs of 85 or their respiratory rate's 40, their blood pressure's 60 if they're in the hotel, then they just activate a hospital. We would allocate the hospital because we developed a matrix with Sydney to distribute the patients across Sydney according to capacity that was available, and then we do a handover to the hospital. But we wouldn't do another medical review unless there was some uncertainty about the vital signs, the patient didn't want to go, or we thought there was going to be a bit of time delay, because we just wanted to activate that process and get it happening really quickly. So we'd do that handover with the information we had. If they were yellow zone or normal vital signs and they met red flags or nursing staff or family were worried about them, we'd do a video or telehealth review. And then we sent about 1 in 6 of those to hospital following review, which meant we left 5 out of 6 at home. Ambulances, we booked all our ambulances through the 131 number. Then we did a verbal and written handover to the destination hospital and provided a time frame for that. So I just wanted to talk a little bit about this, because I think this, from my perspective, was a pretty amazing response from the whole state. So sort of towards the end of July, we realised that we had a lot of people in the SHAR, and we were probably going to exceed the capacity of both RPA and Concord if we were just going to be sending them there, and we were receiving patients from all over the city. So in discussion with all of the LHD CEs, there was an agreement that all of the LHDs would share their COVID capacity, and patients would be distributed to the different LHDs based on capacity. And that was reviewed every day, so we'd take hospitals on and off the matrix. If a hospital became too full or ED was blocked or there was no ICU capacity, they could call their executive and have that hospital taken off the matrix for the next 24 hours. And that was pretty extraordinary. We had really great engagement with the EDs, the physicians in all the different LHDs. I think I've spoken to every ID and respiratory physician across Sydney over the last few months. And we were able to get some really good feedback from them about what was happening to patients when they arrived there as well, which ones probably didn't need to be there, what sort of investigations were happening, who was being admitted, who deteriorated quickly, and that sort of thing. So that's been really, really great. Within that, we were able to put a destination hospital with ambulance as a priority, and we'd do a handover. And then if ambulance had any questions, we provided a number and we could have a discussion with them as well. There were specific hospitals picked for peds, so all the kids went to the Children's Network, either Randwick or Westmead, and are still doing that. If they're pregnant and over 20 weeks, we started only sending them to a hospital with a NICU because it became apparent that a reasonable proportion of those people were needing preterm delivery and or ICU level care, and were probably going to need fairly specialist input for both O&G and potentially NICU for their babies. So we were doing primary movement of those patients to hospitals that already had those services and capacity. Mental health with COVID's been a real challenge, and I'd have to say I don't think any LHD's really got a smooth pathway for that, partly due to capacity, but the complexity of those patients is really challenging. Families, so I sort of go through a few different groups of people that we found particularly challenging, and I'd have to say I don't think I appreciated the scale of disadvantage in our city until I started doing this job. This has really, really shown how vulnerable some families are in our community. So to be put in isolation for 2 weeks meant that there was a lot of food security and financial insecurity issues, and there were some families who only had food for a day and needed food packages sent out. There's been a lot of domestic violence that we've seen. We've had quite a lot of involvement with the child protection services, both with families in the hotels, but also at home. Multi-generational illness has been really problematic. So what we've found is there's probably 70 to 90% penetrance of Delta within a household. So if one person's got it, everybody's got it. If you've got a single mum or you've got elderly people within the household, they're all going to get it. The kids don't get sick, but the parents do. And at the start of this wave, public health were trying to remove positive family members from the household to try and reduce the risk of everybody else getting it. But what that meant is we actually were splitting up a lot of families. So we were putting one parent into a hotel, leaving another parent at home with the kids. The parent at home with the children would become unwell, and then all of a sudden you've got a situation where you've got a fairly unwell adult with children, the other parent's in a hotel, and you have to bring them together again, or you've got a single parent who's become unwell, and you have to manage those children as well. So in the community, we moved the whole family in, and then Westmead set up the unaccompanied minors ward. If they're in the hotel, we were able to look after those kids until we could move them out. But it really added to the trauma of the families, particularly if you'd split up families and then the person at home became unwell. It was also a pretty significant factor in people refusing to go to hospital. So I had a number of pregnant women who were at home with a lot of children, and their husband was in hospital unwell with COVID, and those women became unwell, and our recommendation was that they would go to hospital, and they just wouldn't go because they were worried about the kids. Didn't want the kids to go into hospital, didn't want to leave them with anyone else, didn't want them to go to Westmead. So that was really challenging. DV was and remains a big issue, and I think we probably don't see as much of that coming through the EDs. A lot of it's quite hidden, and even for us, a lot of it wasn't apparent until sort of a week into or anything. Like, that person's really not safe in their home, and what can we do about that to help, because they have to isolate together, and it just increases that risk. Mental health and drug health. I've prescribed more diazepam and methadone than I ever have in my life into these hotels. So people who take a lot of drugs generally do not have secure housing. So a large majority of them either became close contacts in ED when they had their drug-induced psychosis and they were put next to somebody who they didn't know had COVID, or they were in ED for 24 hours because that's what happens when you have drug-induced psychosis and there's no mental health beds. a lot of close contacts from that, but also a huge rate of transmission within that community of COVID. So, and within households without secure accommodation. So that's been really prolific and problematic. Most of them haven't become that unwell with COVID, but managing withdrawal, people coming into hotels who don't want to be there, a lot of pretty volatile behaviour has been really, really hard. Some of those have ended up in hospitals and just torn apart rooms in ICU and the ward. They're really not suitable for hospital. They're generally not fit from COVID. And I don't think there's a good place in the health system to manage these people at the moment. And I think that's something we've seen on a smaller scale for decades, but certainly in relation to COVID, because they need the isolation on top of all of their other complexities, that's been really, really hard. Pregnant women, third trimester plus COVID equals hospital and hypoxia. I think almost every woman we had in third trimester either became tachypneic, developed hemoptysis, needed a review for decreased fetal movements, or became hypoxic, or all of the above. There are only a couple that didn't need a medical review. They didn't all need to stay in hospital, but most of them needed a face-to-face review at some point in time during their illness. And I'm not sure what the impact of vaccination will be on that group. I hope it will be really effective. But I think we're still learning from overseas how effective it will be in that group. Finally, the other big cohort that was really challenging for us, and certainly from a community and paramedic teamwork point of view, was working with the patients who didn't want to engage with a virtual care model and didn't want to go to hospital. So I had a look at, for 1 month, we had 28 patients who refused to go to hospital after an ambulance was called. Most of them were hypoxic, and 9 of them ended up becoming significantly more hypoxic. 2 of them got intubated on arrival when they went on the 3rd escalation, and both of those patients consequently passed away. But the other 19 were hypoxic for a few days, never dipped below 90%, and then got better. And a few of them had things like chest pain but weren't hypoxic. They were a really challenging group, and the reasons behind not wanting to go to hospital were pretty varied. So a lot of the really sick ones had another family member go into hospital and either pass away or go to ICU, or they'd had feedback that experience for that family member in hospital was really traumatic, and they didn't want to go because of that. There were a few people who didn't believe they had COVID, so that was a bit challenging. A lot of people who had caring responsibilities either for children or other disabled adults in the house who didn't want to go. Some people who just had the shits with the whole system or were just cranky. And then there were a couple that on further review with video with family and much more detailed questioning, it was quite clear they just didn't understand what they were saying when they didn't want to go, what the consequences of that were, and maybe they didn't have capacity to do that. So for those people, we've had quite a lot of questions about if somebody doesn't want care, do you provide care? Because they should have the autonomous right to refuse care. But I think in this situation what we found is if we kept calling, eventually they would engage or they'd get better. And they'd engage when they were more unwell. So we had a few patients who we had ambulances come 2 or 3 times for. We did 3-way conversations with patients, paramedics, family and us, and often that was enough to encourage that patient to go to hospital. If they still refused to go, we would safety net with family, with friends. We would call them again. We'd make sure there's a video review. If they didn't answer the phone when we called them again, we were also doing welfare checks either with our community nurses or with police. And from under our care, we didn't have anyone at home die with known COVID over the last 3 months, and I think that's because of the vigilance over this group, which I think are probably the highest risk group. So that's what I thought I could share with you today. Any questions?
Thank you very much. I'm just going to go to the microphone and see if there's any questions in the audience. I guess my question is, how big is the staff? How many people have you got working in the virtual hospital now?
So I started here in May. I thought virtual care is sort of the way to go. It's the way out of all of the flow problems in the hospital, and it's a really interesting space. I didn't think I'd be doing this. So when I started, there were 2 FTE of consultants. myself and I was 0.5, another FACEM was 0.5 and the clinical director, and we scaled up all the way to 4.5 FTE of consultants at our peak, with a host of other people coming in on registrar roles doing random shifts. So anaesthetists who'd had their list cancelled. We've got a few registrars. For a while we had all the unvaccinated doctors. So we managed at our peak with 4 doctors on a day shift, 2 on an evening shift and 1 on a night shift, and just did what we could, and we just had to triage. So the busier we got, the more we triaged to the sickest people. If they met the red flags, we'd just send them, and the handover was fairly brief. But we managed to get to everybody. We're doing about 100 patient reviews a day at our peak.
Yeah, wow. I mean, that's amazing patient to staff ratio. 3,000 patients and 4 FTE staff specialists. The anaesthetist wouldn't understand that concept. Wow, that blows my mind. The other quick question I had was the saturation monitoring. Was that just a simple finger sats probe with no interactivity or no connectedness, or was it
Yeah, so we've got Bluetooth enabled oximeters, but unfortunately we don't have a dashboard integrated into EMR to make that useful. So it was really just the nurses do all of their reviews with Zoom calls. Okay. You ask the patient to go into a room that's not well lit, and if there's an issue with the SATS probe, you turn the lights down, because some of the SATS probes have got interference from bright light.
Yeah.
And check their SATS with that. There were quite a few problems with patients not charging them. Then there was a point at which we had a lot of patients and not enough SATS probes, so we went to non-Bluetooth enabled ones as well. We've gone back to that. We are building a dashboard to try and integrate that into EMR, but that's a much bigger project. It just wasn't ready for this wave.
Okay, well that's really useful to know. I mean, I guess with more time and more planning, that could become a bigger part of it, that sort of remote monitoring. I guess the other question I had was, how much do you think video added to just phone calls and, verbal?
That's a really good question. I think it depended on the patients. I think in kids it adds a lot, particularly if you're trying to do a work of breathing assessment. You can't really do an accurate respiratory rate over video or over phone call. So our assessments on respiratory effort were really about how is the patient talking, how are they looking, if you get them to walk around, how out of breath do they look. I think it added a lot to the trust and connectivity that the patients had with the service, because they would talk to the same nurse each day if they had multiple reviews, and I think the engagement was really improved. From an information point of view, I mean, sort of 80% of your assessment is a history, and I think you can do a lot of that over the telephone, and we certainly did a lot of our medical reviews just with a telephone review because it's quicker, particularly if you're trying to use an interpreter as well. But I think the role of video is actually quite important, and I think we probably underestimate how much that helps with the patient engagement if they can see your face. Yeah,
I guess that works both ways, doesn't it?
Yeah.
Excellent. Just a couple of questions have come through our WhatsApp group. One comment from Brian, excellent effort, Beck. How did you manage the homeless population? So that was the first question. And the second was, what percentage sent to hospital were discharged back home or to the SHA within 24 hours?
So good questions. Homeless population came into the hotels, and they got a wonderful hotel stay with 3 meals a day. Yep. And we had a lot of homeless people. Percentage that went into hospital. So 80% of patients we sent in got admitted when we reviewed our first 1,000 patients, and we kept to the same protocol, and I think it's been roughly the same. The ones that generally come home are those with chest pain. So a lot of the reviews we did were for chest pain. It's really, really common. And we probably only send in maybe 1 in 4 people with chest pain for further investigations with blood tests, chest x-ray and an ECG. And a lot of those you kind of think, look, you're probably fine, but you've got enough pre-morbid risk that I really want an ECG. Or my test in my head was, if you walked into my waiting room and you had described that chest pain, would I be happy to send you home with no tests at all, no ECG, no chest x-ray, no bloods? And if the answer to that is no, then I should probably send you into ED to get those. So a lot of those chest pains you'd send in anything, it's probably all pneumonitis, but it could be a PE, so I'm going to send you in, knowing that if the first few investigations are negative and the patient looks well in a face-to-face assessment, they're probably going to come home. The other one was we had a few patients that we'd send in with exertional hypoxia who sat in ED for 6 hours, no hypoxia, no workup, and they were sent home again. About 1 in 4 of those became more hypoxic in the next 3 days and needed to go back in. But a lot of them were fine. That was actually a pretty low volume of patients. Most of the people who were hypoxic with us were really hypoxic.
Okay. And did anyone need, or did anyone get oxygen outside of a hospital situation? So when anyone treated in the shower
so we
with
have oxygen now in the hotels, just because I was quite worried that with increasing volume there'd be increasing delays to being able to transport them because the system was so stretched. So we have oxygen as an interim measure for people who are profoundly hypoxic, but we actually haven't had to use it yet because the response from the ambulance service was always really, really quick.
Okay. So I'm dominating the questions. Any questions from the rest of the group?
Hi, it's Fraser. Coming from the UK and seeing this, I think this must have made a massive beneficial impact to the hospital population with the number of patients you've kept out with the system. I presume that the service was set up prior, or the idea behind the service was pre-COVID.
So ours was...
Sorry, Beck. Where do you see things going once COVID settles down? And my second question would be, would you have taken on the role had you known COVID was going to be a thing?
So I was actually fortunate enough to get 2 jobs sort of at the same time. I got a 0.5 at RPA ED at the same time. I was at Bankstown for 5 years prior to that, which was a job I really loved. But I was after a bit of a change. So I did that for a week, and then I got seconded into this full-time to manage the COVID outbreak from a community perspective. I probably would have done it anyway. I think it's type B fun, like when you run a marathon and it's awful and it hurts, but afterwards you're like, yeah, that was really awesome. So while I was in the middle of it, I was like, I really could become a farmer. I was quite good at retail. Maybe I could go into something else. But now we're sort of on the other side of this wave. It's been an extraordinary learning experience. And I think it really has provided a foundation for us looking forward to virtual care about what's possible with very little. So as we get better technology integrated into the way our systems work, I think it's really going to pave the way for acute care into the future, and also integrating acute care back into the community. What comes next? So we've started, our numbers have dropped, but we figure we've got maybe 3 or 4 weeks before the numbers go up again, but we expect the acuity of that group as the numbers go up again will be much lower because of the amazing vaccination rates. So we don't want to look after people in a virtual hospital who are very, very low risk of becoming unwell and needing hospitalisation. It's just not a great use of resources. So we're doing a very big body of work at the moment trying to integrate primary care into the care of people that we would consider low and medium risk. So still providing oximeters to people who are medium risk, but asking primary care to take over the monitoring and observation of that group, as well as the de-isolation part of it. Yeah.
Cool.
Hi Beck, it's Maddie. Hello. I just wanted to ask, did you find that older people or people without English, how did they uptake the online experience? I wondered how that went with people who maybe were a bit more technically challenged.
Yeah, much easier if they had someone else in the household who could help them. We used interpreter services for about 15% of our patients. So that was a reasonably high proportion, and it certainly made it a little bit more challenging. The main issue with older people is they're just bloody tough and they don't complain. We talked about the happy hypoxia. I kind of think that's a misnomer. I don't think anyone's happy, but the older people tend to feel a bit crap, and they don't feel any more crap when they become hypoxic, and they don't get any work of breathing. So you call them and they had no effort in their breathing but had sat in the 80s, and you'd be like, look, you're quite sick, you really need to go to hospital, and they'd be like, no, I'm fine, I'm going to go out in the garden, just leave me alone, I don't need you. And generally it was almost everyone who refused to go to hospital who was genuinely very unwell was over 60 and cranky. But we engaged a lot of family, so even if that person if it was an older person at home by themselves, we would get family to join us on calls or to call beforehand to warn them that we were going to call, to help them set up iPads and that sort of thing. Yeah, so lots of partners in care for that group.
Cool. Thank you very much for a great talk, and very well done on setting up what seems to be an amazing service. I know you've got another meeting, I think, at 12 o'clock, so we will let you get away and say thank you very much.
Thank you.
Thank you.
Nice to see you all. I hope it's a good day.
Thank you. Take care.
Thank you.